I'm going here to talk about the Utstein 10 programs for emergency stroke care. I'm honored to be here in Australia. Thank you for the invitation. I'm honored to speak on this subject, especially in Australia and New Zealand, because you are leading in this area and you have took some of the initiative to get this rolling. You have my affiliations, you'll get my contacts, and you'll get the PowerPoint if you want to. I'm from Denmark, small country, 5.8 million people in Scandinavia, in Europe. I marked it, this is not Denmark, it's all of Europe actually, but it was just to compare to Australia. Europe has about 500 million inhabitants there. We have had some people going to Australia, and we have at least had one from Australia going to Denmark, and that is the Crown Princess of Denmark, which is from Tasmania, very popular in Copenhagen and Denmark as well. I'm also here to represent the European EMS Leadership Network, which corresponds to the CAA here in Australia and New Zealand, and they have been pushing this work forward as well. I have to conflicts of interest and acknowledgement. I have to acknowledge that we get support from the Danish Foundation, who supports emergency patient care in Denmark for a safer country, and also the Lippert Foundation for supporting the GIA meeting, and also for supporting this Utstein meeting that came up with this work that we are doing. Also the Danish Resuscitation Council supported that meeting. Contributors, I'm here also on behalf of the Utstein Group of Emergency Stroke Care, to present this work, and we had in total 32 people coming, experts, to the Utstein meeting, but 4 of them were from Australia and New Zealand. David Waters from New Zealand, Anna Ranta from New Zealand, Chris Bladin, which is well known as well, and Mick Stevenson contributed, and that's a huge contribution compared to the countries, and that was actually taking part of coming out with these guidelines as it is. The work started 1 year ago. We have finished the works, meaning that we have come to a conclusion and come to 10 steps programs, which I'm going to present to you. But we also have published, or we have submitted it for publication. So what I'm going to show you is, we don't know exactly if that's going to be the final version of what is being published, because it's under review and for some comments there. So that's just to make some reservations for what the final outcome of the publication will be, but hopefully soon. Participants, 32 different participants from all over the world for this Utstein meeting. You cannot see those, but you'll get the full list later. And this is the pictures from the Utstein meeting. What I'm going to talk about is shortly stroke, the challenge, the new data on stroke, new treatments. That's going to be very short. You have experts in Australia and New Zealand that know much more than I do. 2 tales of a stroke patient, that's going to be a movie. A question of how do we improve survival and outcome for stroke patients. And finally, if we could translate, and that was the idea that turned up in the GIA group, Global Resuscitation Alliance group, and actually promoted by David Waters, that could we translate the 10 programs for stroke, for cardiac arrest care to stroke care. And then we had the Utstein meeting, and then I will show the results, mainly the targets we have and the 10 programs, and also a figure of a chain of survival for stroke care. Stroke is we have just heard about statistics. Stroke is an increasing burden, you can say, in the society. You have elder population, and 45% increase in death from stroke will be foreseen for the next 20 years, actually. 12% of total death worldwide. We have 80 million currently having a stroke, and it's at probably 2% of the EMS population. Cardiac arrest is less, but you have much more stroke patients in the society, and also in EMS handling. 50% of the patients, they don't know that they have a stroke or that this is a severe disease before calling, actually, and access varies within countries and even within individual areas. These are predictions over the next 20 years. If you can predict for 20 years from Europe, you can see the numbers there. It's nearly the same, and I would guess it would be the same for Australasia as well. So this is a huge burden, and we have to handle this in a different way than we have been doing. Otherwise, we're all ending up working in healthcare in the community. There's a comparison of myocardial infarction that I would like to make here, because myocardial infarction, as it was called at that time, and compare that to STEMI or stroke, often it is the same disease in two different vital organs. They are both major causes of death and disability for the citizens, for the community as well. Myocardial infarction used to be hospitalized, and then we waited for the patients to see the outcome and to treat the complications. That was how we treated that years ago, many years ago. Then we got STEMI is now an emergency. Patients know that. They call, we go out, we start treatment, we start thrombolysis, advanced pre-hospital care, and we take patients to centralized care in cardiac centers for PCI. And the prognosis for STEMI has changed dramatically over the years. So this is where we are with stroke today, except that we for stroke have treatment that does work. We have had that now for years. So we have thrombolysis and we have endovascular surgery that will reveal these patients' pain and avoid disability for years. And we have that new evidence in hospital. We have that before we actually had that for cardiac arrest. So now is the time to act on these data. But we cannot act on these data unless we have a pre-hospital care involved in that system and the patients involved in that system, because stroke doesn't give any pain, and patients are not aware of that stroke is the symptoms of strokes, that some don't realize their symptoms actually, and stroke is a time-critical incident, and they don't know that. They don't know even that we are capable of treating that sufficiently today, and they don't know the time limit for that, and therefore they don't call the emergency number for an ambulance. They wait until it's too late, most of them, and this is why we have to change that system. So lack of awareness of symptoms and treatment is one of the major challenges. Current care is inconsistent. It requires specialists in hospital more and more, as we know, unless we are going to have mobile stroke units, as you have introduced. So we need to optimize the emergency stroke care. And I want to show you two cases of one patient. With two different outcomes. these two cases, these two different outcomes, we all know that. We all have seen the bad outcome, we all have seen the good outcome. And the difference here is actually how we behave in healthcare, but also how the community act, the awareness from the citizens, and how they use the dispatch center, and if we centralize care for patients. So this is what we're going to discuss at the Utstein meeting. How could we optimize that? How could we actually improve stroke care? Utstein is the term for Abbey in Norway, where they started the guidelines for resuscitation, the terminology years ago in the 90s, and everybody worldwide have been working with these templates coming out there, the recommendations coming out there for the last 25 years, actually. So this was the 25th anniversary meeting we had, setting up a meeting there. And we thought that maybe we could use the knowledge we have from the Global Resuscitation Alliance and the Resuscitation Academy with the 10 programs and the 10 steps and the recipe for how to improve cardiac arrest care and the chain of survival there. We thought that it might be possible to translate that into stroke care. Some doubted that it was possible, others were convinced that it could actually be done. We looked at the papers being available for that. It's all on the website as listed here, and with a lot of interactive material as well, and good cases of best practices. We had the science already for stroke care, what to do. We know that. We have the documentation. It's not for discussion. We have guidelines, international guidelines on how to treat stroke care, stroke patient, at least in hospital, but we missed some of the pre-hospital part. And we have education, at least in hospital, for stroke care. But what we want to focus on is how do we implement the science, the guidelines, and the education we have, and how do we make that chain of survival for stroke care patients. So it was actually about transferring the methodology from Utstein into emergency stroke care. We met at Utstein 1 year ago. We looked at implementation. We had 32 different experts from not only from stroke physicians and neurology, but also from EMS, so it was half of half from the international experts coming there, and you have seen them. We had 5 groups, actually 6 groups that we want to discuss, establishing a stroke registry, early recognition, pre-hospital care, emergency department care, public awareness as well, and also accountability and culture of excellence. You might recognize that from the Global Resuscitation Alliance, and we have chairs for these. I'm not going to mention all the names that contributed to that, but you can see it. A lot of countries were represented, including the AHA and the Stroke Foundation in Canada. And what came out of that? 10 programs for stroke care. We ended up with 10 programs. We might be able to modify that to fewer programs, but we think actually 10 is a nice number to work with. So the first one is to establish a stroke registry. Most people, or a lot of countries, have stroke or have registries for cardiac arrest, and you cannot manage it what you cannot monitor and what you don't have a data for. So this is very important, but it is also difficult. Few EMS organizations actually monitor their stroke patients, and they have very little data on their stroke care. They do have that in hospital, and what we would like to merge is actually the pre-hospital and the in-hospital data for stroke patients to follow up on survival. The next one is create public awareness. If half of the patients are not calling the emergency number, half of the patients lack the options of actually getting help there in due time. So what we need to create is actually public awareness about the symptoms, having campaigns nationally, locally, and putting into first aid courses as well, and making people aware that if you have some of these symptoms, you should call the emergency number. If in doubt, you should call the emergency number. I know the dispatch center would say, my own people as well, this will lead to a lot of people who would call us for no reason. Yeah, but this is what we have to do to help those people that really need it, and this is our task. We have to find other ways actually to sort them out, and we have to find other ways to make sure that we can take that workload on. So create public awareness. We need that kind of campaign. The American Heart Association have had a campaign in US. Others have done the same, but it doesn't have the impact because when we go and ask people, they are still not aware of the symptoms of stroke. Start public education. So this is part of it actually. And we have different means. In the paper, we were going to list different means on how to do that. We have examples of how successful public education could be. I think it's very necessary to put that into the first aid courses as well. And you could also put it into the CPR courses that we are running, just mentioning shortly the symptoms of stroke and be aware that this is an emergency also. Improve early recognition. That could be improvement by the citizens, by the bystanders, and it could be by the dispatchers. So we have to work with recognition in all these phases, actually. And we will come back to that later. When the ambulance arrive, how do they recognize that this is actually a stroke, and how do they realize whether it's going to a centralized stroke center or not? So improve early recognition is very important. And you saw the chain of survival from cardiac arrest this morning by Richard Lyon, and it's about the same. The first link is much bigger than the other compared to the impact it has. So practice rapid and timely dispatch, which is important. So the dispatcher have to realize that this not only recognize it early, but also have to realize that you need to send an ambulance with lights and siren and the right personnel there, and not wait. People don't want to have an ambulance with lights and siren unless it's necessary, but we have to practice that. Optimize pre-hospital stroke care and triage. What does that imply? Well, this is the task of the paramedics actually, and the physicians working pre-hospital or nurses, depending on which country you're working in, but we have to optimize that. And that doesn't mean that you have to do a lot of advanced things pre-hospitally unless you have a mobile stroke unit. If you don't have that, the advanced thing is actually to identify stroke and then make a fast track to the right facility where the patients can be treated. So triage is the most important here. For some systems, it means that you will be fast tracking these patients. You will be like scoop and run, and for others it means that you will do more pre-hospital. It depends on how we are developing EMS in the future and what kind of treatment option we are developing. But this is for the time being what we are going to do in 20 and not in 2050. Optimize in-hospital basic and advanced care. That is in most countries, in most hospitals, it's already done, but some neglect some of the basic care for these patients, leading to complications. And we have a huge discussions, some places, whether we should actually centralize care. I know you have that discussion here in Australia, but it's a different question because Australia is a big country compared to many of the European countries. But centralized care seems to benefit the patients. So, but it depends on the distance you have, of course. Use smart technology. That can be applied for any of these, and this is one of the 10 steps also. You can use smart technology to identify these patients. You can use smart technology for the patient to identify the symptoms. You can use smart technology actually in education, so we should do that, and this is going to help us a lot. We have some cases in the best practice cases following that publication that will reveal that. Demonstrate accountability, meaning publish your data, publish your annual report like you do with cardiac arrest within your organization, within the EMS system, within your dispatcher, and within your hospital, and ideally within your region, state, and country, so that you can see how you progress in this area and benchmark with other. And the last one is creating a culture of excellence. That is actually creating the whole system for the patient, and just like in cardiac arrest, say that no one's going to die on my duty. So meaning that you will do the best for each individual patient all the time, and that should be that should be a culture in the organization. We could look at that in another way. I know YY has a picture of the CAA19 programs as a sandwich, but this is actually another way to look at it. So you have the stroke register, and you cannot improve what you cannot manage. So that's the basic, though it's on the top. Then you have the pre-hospital setting, the red one, early recognition, rapid and timely dispatch, pre-hospital stroke care, and then in-hospital transfer of these patients. But before that, you have the step 2 and 3, which is public awareness and public education. That's a basis for this. Otherwise, they won't get in contact with you, with us, and they won't get the care that they should have. And then you have smart technology, accountability, and culture of excellence to support it all. It goes in each of these steps, actually, and supports it. We tried to make and this is a proposal, chain of survival for stroke patient. So it's community awareness and call for emergency help. It's the dispatcher, rapid dispatch, and early recognition, very important. But it's also early transport and pre-hospital care according to the local protocols, and early revascularization and advanced care. That could be done pre-hospitally, or that could be done in hospital, depending on your system. And then, of course, rehabilitation, which is important. So this is, though it's equal links in the chain of survival, the first one might be the biggest one compared to the impact it has. And we should be aware of that. But this is the current version we have worked on. The other thing is that we would like to put up with some suggestions on the patient journey, time limits, and it can be discussed. Of course, recognition, and you can realize the steps here as well. But here, stroke community recognition, we cannot give a time on that. It should be as short as possible, but that's why the awareness and education comes in. And then they'll do the emergency call, and then we will have a handling that call and identification that this is an emergency. And we came up with about 1 minute, which is correlates to the stroke, to the cardiac arrest goals we have there. Response time will depend, of course, on your local system geography, and also on-scene time will depend on what you're doing. But usually you shouldn't, if it's a scoop and run, you shouldn't use more than 8 minutes for that. That's the aim for we are coming up with. Transport time is the next one to hospital. 15 minutes sounds unrealistic in Australia, so it of course depends on the system you have, but this is meant for a supposed urban area. And door-to-needle time, 45 minutes. Some say this is the realistic goal, others say it's not realistic, but we have to aim for that. Some will be able to do it actually in 25 minutes. So these will be for discussion in the future and will hopefully change. And then rehabilitation will continue. But the earlier you start, the less rehabilitation you will need. So in summary, what we have been doing is looking at stroke and that the major challenge we have. We have a lot of patients with stroke that we don't give the right treatment currently. We have new evidence on best practice for stroke care in hospital. And if we are going to avoid the bad outcome from the first movie and go to the best outcome in the second movie, we have to implement a chain of survival for these patients. And that was what we came up with, these 32 different experts coming up with, translating the cardiac arrest 10 programs into 10 programs for emergency stroke care, including a chain of survival and performance targets that will be discussed. It's going to be published We're going to revise what we have according to the reviewers' comments we have had, and it's going to be in additional material with 28 different best practice cases from internationally, and I'm glad to say that a lot of them are actually coming from Australia and New Zealand, meaning that you are actually leading in this field. And then just an announcement, European EMS 2020 will be in Scotland, and in a few days you'll know which the exact dates and which city it's going to be. I hope to see some of you there for the European EMS Congress as well. Thank you.
Freddy, thank you very much for the presentation. And we do have a couple of minutes here in our program if anyone has questions for Freddy at this particular juncture. Very happy to race around the room with a microphone as well. There was somebody at the back there? Oh, fantastic stuff, thanks.
Thanks for your talk, Freddy. I'm a big believer in registries, and pre-hospital stroke registries are difficult because you're relying on the hospital diagnosis to have the definitive diagnosis. Have you got any examples of ambulance services that have got good stroke registries?
Yes, I do. We have ambulance services or dispatch centers who have registries, but I haven't any examples of where we actually combine the pre-hospital registers with the in-hospitals. And you're right, cardiac arrest seems to be a very easy thing to measure because you know when there's a cardiac arrest, but you are an expert within that area, and we know that there's a lot of discussion whether this was cardiac arrest or not cardiac arrest, and that it has an impact on the survival rate. But the best registry would actually be able to look at the final diagnosis and then go back and see what was the cause of this patient, and what was the time limits, and what was identified and what wasn't identified. So when we combine, in Denmark we are capable, because we have a unique social security number, so when we combine the in-hospital with the pre-hospital setting, it seems that we only 20% actually call our emergency dispatch center, and they get access to advanced care in hospital. Those who don't, they don't get any access. So there's a huge potential actually to improve, and I think we can only improve by putting the in-hospital data together with the pre-hospital data. But we could start with at least the symptoms, and then, like cardiac arrest, see if we identify most of them, or if we identify too few, actually.
Thanks, Freddy. Thank you for the question as well. We have time for one more. If there is a burning question right in the centre of the room, when there is, I will zap on through.
Thanks, Freddy. With the chain of survival for out-of-hospital cardiac arrest, there's been a big shift to recognise dispatch as the big circle. With the chain that you've proposed for stroke, are you seeing which part of the chain would have a big emphasis at this stage?
Sorry, which...
So, yeah, with some of the figures around the chain of survival for cardiac arrest, there's now, you know, the big early part of the link in the chain is now being emphasised. Do you see a similar thing with stroke where a part of the chain will get that emphasis?
Absolutely. I see, and the group see, that this is just as important. If you want to get to the advanced in-hospital treatment, you have to put emphasis on the pre-hospital part. Education, but also when people are calling, identify those who are calling. And then, of course, if we miss some, and we do miss some when they call to the emergency number, then the paramedics should be able to catch up those patients and direct them to the right care. Because stroke symptoms are not that easy. Actually, it's only about 20% of the stroke patients who has the three typical symptoms. So usually it's a combination, comorbidity and other things, so you have to be very precise. I hope that tomorrow I'm going to talk about artificial intelligence in dispatch. I hope that artificial intelligence will be able to help the call takers to identify more cardiac arrest than they actually do at the moment.
Cool. Thank you very much indeed. Ladies and gents, round of applause, please, for Dr. Freddy Lippert.
Thank you.